This is the second seminar in the round series of the forum Kajian bersama, which is a rotating event together, a collaboration with several universities, with World Bank and other think tank institutions. We are very happy today to have Margaret Triyana, or affectionately called Maggie, to present her job market paper, Do Healthcare Providers Respond to Demand-Side Incentives? Without further ado, Maggie, thank you very much.
Thank you. Can everybody hear me? This is good? This is good?
Yeah.
All right. So thank you all for coming. Before I begin, I'd like to acknowledge support from the Hewlett-I Dissertation Fellowship and the Harvard Kennedy School Indonesia program. I'm also grateful to my advisors, Bob Lalonde, Dan Black-Kerwin, Charles Fiona Marinescu, and Rima Hanna. So in this paper, I analyzed whether or not a demand-side health intervention affects the healthcare market in terms of utilization, quality. I apparently don't know how to do this. Utilization, quality. Okay. Make it better. Thank you. No. All right, let's try this. Is this? Okay. Is this? Yeah. Nice. All right. No? There's a sweet spot. No? Okay. Oh. No time to charm. Okay, here we go. So in this paper I study how a demand-side health intervention affects the healthcare market in terms of utilization, quality, and whether this changes healthcare prices. The particular program that I study is the Household Conditional Cash Transfer Program, which I think most of you are familiar with, but for the sake of those who might not be familiar with it, the program essentially provides poor households with a cash transfer so long as these households meet the pre-specified program requirements, which include health and education, typically prenatal visits, vaccinations, and sending the children to school. So this program combines poverty reduction and human capital investments on children. In Indonesia, most of you know this program Keluarga Harapan PKH. In this paper, I focus on the health requirements, particularly because the healthcare market is directly affected by this program. So in particular, I look at how the CCT affects utilization as measured by the use of a trained delivery attendant, so it's a doctor or a midwife for delivery assistance instead of untrained traditional birth attendants. I also look at the effect of the program on healthcare prices as measured by delivery fees, and whether or not this program affects quality as measured by prenatal care quality, which I will talk a little bit more about when I describe the data. So the program is very well established that it's effective in increasing utilization, not only in Indonesia, but also in other countries. However, this program could also affect quality, in particular, as we see better health-seeking behavior, the result on health outcomes are actually mixed, and quality is potentially the missing link here to translate utilization to health outcomes. In particular, what we have in mind is it's possible that because of the demand increase, providers now see more patients, and so the quality per patient might actually be lower as a result of the program. And beyond utilization, it could also affect healthcare prices. Increased utilization through the demand shock may increase prices, and this particularly speaks to the affordability of healthcare among households that may just miss the cutoff for the CCT. So a brief outline of the talk. I'll go through the theoretical effects of CCT on price and quality and a brief literature review. I'll then describe Indonesia's healthcare system and then a quick overview of the program. And then I'll talk about the data and the empirical strategy, results, and then conclude. So what the program does is it generates a demand shock in the healthcare market. In the short run, with a fixed supply of healthcare services, we expect to see price to increase and quantity to increase. To mitigate this price increase, PKH was actually implemented in areas that are considered supply ready. So there are enough providers to be able to meet the additional demand from the program. And in the long run, further supply response is also possible. On the extensive margin, we might see more providers entering treated areas. On the intensive margin, we might expect to see existing providers to increase their hours. This paper is very closely related to existing literature on CCT and prices. In particular, Angelucci and DeGiorgi find that there is spillover in consumption among non-participants, but they find no price increases in the goods market. And Fishman et al. Generally find that there's no significant effect on local prices or wages. So in terms of the general equilibrium effects, the CCT seems to have no significant effect. This paper, however, focuses only on the healthcare market. We expect to actually see a general equilibrium effect here because the shock is exactly in this market. So this is a much more focused setting to look at potential general equilibrium effects. Next, I look at quality of care. This is an important component to study because when we think of quality of care, it's an input to the production of health outcomes. And one potential explanation for the lack of birth outcome results could be that increased utilization may lower quality, but on the other hand, CCT programs also provide maternal and child health education for these women. And in Mexico, with improved knowledge, there's actually higher prenatal quality, and this leads to better birth outcomes as measured by average birth weight, and a lower incidence of low birth weight as measured by birth weight less than 2,500 grams. So overall, the effect of CCT on quality of care is ambiguous, and that's something that I address in this paper. A quick preview of the results. Among program participants, I find a 40% increase in the use of midwives for delivery assistance. I use midwives here because they're the main providers in the area. This is very consistent with the result from the impact evaluation that finds increased utilization of both midwives and doctors. I also find that participants report paying higher fees for delivery assistance to midwives, which amount to about 30% of the transfer. So when you think about providing additional resources to poor households to be able to obtain education and health services, this program is successful in doing that. Program participants also report receiving higher prenatal quality, but consistent with the impact evaluation, there's also no effect on additional birth outcomes here. And when we turn to the supply side, I use the midwife report here because midwives are the main providers and they see both participants and non-participants. And given that there's an average of 1 midwife per village, the midwife report actually captures the local market conditions quite well. So midwives report a 10% increase in delivery fees, which suggests that there is a price effect as associated with the program. Midwives report no significant change in prenatal care quality provided, so it doesn't look like they're doing anything differently. And when we try to compare the household result and the midwife result, we see that the quality increase among program participants is really driven by increased utilization among program participants and not driven by changes in the market itself. I know most of you are very familiar with Indonesia's healthcare system, so I'll spare you that detail, and I'll just focus on the midwives. Most midwives are employed by the government. So they're civil servants, but they, in addition to their salary, they get to charge fee-for-service payment for every service that they render. They're allowed to have dual practice, so they can have private practice on the side, and 90% of them actually do have this private practice on the side. And private practice is substantial in Indonesia. About 50% of their income actually comes from this private practice. So midwives with dual practice would have two sets of prices, one which is their public price, and then the other one is the private price. Public fees are generally regulated by the Ministry of Health. Typically at the district level, there's a maximum price for the services that they can charge. So in relation to the CCT program, we expect to see the price changes to come in through the private practice and not through the public practice. A quick program background. PKH was piloted in 2007. It's randomized at the sub-district level because clinics and secondary schools are provided at this level. 259 sub-districts were randomized into control and 329 into treatment, with good balance between Java and off-Java areas, and more importantly, with good balance between treatment and control within a district. The government employed a proxy means test to identify and then enroll extremely poor households. This is about $1 a day households. It's very targeted to expectant or lactating women and also households with school-age children. The transfer, like other CCT programs, is made to women, and it's done through the nearest post office every quarter. The compliance is checked every month, so the transfer is made after compliance is verified. The transfers range between $60 to $220 depending on household composition. This amounts to 10 to 15% of expenditure. This is very much in line with other CCT programs. The data here comes from the Impact Evaluation Survey. In particular, I focus on the survey of ever married women and the provider survey, which surveys midwives. The quality of prenatal care that I use here is a quality index, which I create using principal component analysis of prenatal care items. So women are asked whether or not their weight was measured, their height, blood pressure, fundal height, fetal heartbeat, blood and urine test, external and internal pelvic examinations, whether they received 0, 1, or 2 tetanus toxoid vaccinations during their pregnancy, whether they received any iron pills, and whether they received any information on pregnancy complications. One of the targets of the program is to increase the receipt of iron pills during pregnancy. We worry that that might affect the quality index, so I've created an alternative index that excludes iron pills, and the results are qualitatively similar. So this is the baseline characteristics of households in terms of delivery assistance. The parenthesis is the standard deviation, and the adjusted difference takes into account district fixed effects. So the use of trained attendant is quite high. This is actually in line with the DHS. 62% of births in control areas were attended by either a doctor or a midwife, and 64% in treated areas. The use of doctor is quite low in the sample. It's at 9% in control areas and 8% in treated areas. Midwife use is quite high. This is actually the majority, which is consistent with DHS data, about 56% in control areas and 59% in treated areas. The use of traditional attendant, these are completely untrained and can be quite dangerous in some instances. The use of traditional attendant is quite high at about 43% in control areas and 42% in treated areas. There's good balance in the number of observations between control and treated areas. The adjusted differences are not statistically significant, and they're also not jointly significant. So we see that there's good balance between control and treated areas at baseline. So the randomization worked. A little bit more on prices here. This is the baseline delivery fees paid to providers. This is the unconditional fees. So a household that did not use a doctor would pay $0. A household that did not use a midwife would pay $0. The average fee paid to a trained attendant is about 250,000 rupiah, and in treated areas it's about 240,000 rupiah, so the difference is very small and it's also not statistically significant. For the use of doctors, because utilization of doctors is so low, the average expenditure on doctors is about 100,000 in control areas and 80,000 in treated areas. The use of midwives is quite high. The average expenditure on midwives is 170,000 in both control and treated areas. Conditional on using a midwife, they pay about 300,000. And for doctors, conditional on using a doctor, they pay about 1 million. Yeah. For traditional attendants, the average expenditure is about 40,000 in both control and treated areas. Conditional on using a traditional attendant, the average spending is 150,000 rupiah. So we see that the trained attendant provides the service for a much lower fee. Of course, you're also getting a much lower quality. But again, it's a combination of potentially credit constraint or some sort of preference. What the CCT should do is to move up people who would have liked to use a midwife but didn't have the resources to actually start using midwives. The adjusted differences are not statistically significant, and they're also not jointly significant. So there's good balance here at baseline. This is the baseline midwife characteristics. Their average monthly income is about 3 million rupiah. It's quite substantial. The adjusted difference here is significant at the 10% level, but this can be attributed to chance. When I look at the differences jointly, they're not jointly significant. The share of private income is about 47% in both control and treated areas. It's very much in line with the estimate of 50% in Indonesia. The public fee that they charge for a normal delivery is about 130,000 in control areas and 150,000 in treated areas. The private fee is about double that at about 300,000 in both control and treated areas. So for the empirical strategy, the estimation is done using a difference in differences approach. The first parameter that I estimate is the placement effect, which is very much similar to the impact evaluation. In particular, I estimate the reduced form effect using this equation, where Y here is the outcome of interest for woman or midwife M at subdistrict S and district D at time T. So this is the average program effect for people who happen to live in subdistricts that are randomized into treatment. Because of the randomization, the treatment assignment, the CCT indicator, is not correlated with the error term, so beta here is the parameter of interest. This is a slightly different specification from the impact evaluation, but the results are actually quite similar. I include here the baseline value for the subdistrict Y bar DS1. I include district fixed effects, and all standard errors are clustered at the subdistrict level, which is the level of randomization. The second parameter that I estimate is the participation effect. This is the effect of actually receiving the transfer. Because household participation is endogenous, these participants are actually selected into the program. To address this endogeneity problem, I use an instrumental variable strategy where the subdistrict randomization is used as instrument for this individual participation. I include the following baseline covariates for efficiency: education, age group, log per capita expenditure, and asset ownership. District fixed effects are again included, and all standard errors are clustered at the sub-district level. So this is the first set of results. This is the placement effect in terms of utilization. The first column is changes in the probability of using a doctor for delivery assistance, followed by the use of midwife and traditional attendant. This is estimated using a linear probability model. When I use the logit, the results are qualitatively similar. So among households that happen to live in treated sub-districts, there's a 4 percentage point increase in the probability of using a doctor, which is about a 50% increase off of baseline value. There's also an 8 percentage point increase in the probability of using a midwife. That's almost a 20% increase off of baseline value. And there's also an 8 percentage point decrease in the probability of using the untrained traditional attendant. So using these results, it looks like there's a substitution between the use of traditional attendants into midwives, and there's a slight bump in utilization overall through the increase in the use of doctors. This result is also consistent with the impact evaluation that finds a general increase in the use of both doctors and midwives. This is the participation effect, so this is the effect of actually receiving the cash transfer. The first column is changes in the use of doctors, followed by midwives and traditional attendants. We see here that the coefficients are larger, which is expected given that the program is targeted to these people. There's an 8 percentage point increase in the use of doctor for delivery assistance. That's almost a threefold increase off of baseline. There's also a 17 percentage point increase in the probability of using a midwife. That's about a 40% increase off of baseline. And again, there's a 17 percentage point decrease in the probability of using a trained attendant. So here we see the same sort of substitution pattern going from going from traditional attendants to more midwives, and there's a slight increase in utilization overall through the use of doctors. In terms of access, we see that the CCT is successful in improving access to healthcare services for these people. And in particular, the increase in the use of doctors and midwives actually means that these households now use doctors and midwives at about the same rates as non-participants. So in terms of access, the CCT is very successful in improving that. There's also an increased use of midwives for prenatal care among program participants. And this is only true for program participants. The effect is actually not statistically significant and when I look at the placement effect. This is the participation effect in terms of birth outcomes. The first column actually comes directly from the impact evaluation. The second column is a replication that I did using the slightly different specification, followed by changes in maternal mortality and height for age for children under 2. So these are children who were born after the program's implemented. So comparing columns 1 and 2 for infant mortality, which is defined as deaths between 0 to 11 months, we see that the estimates are very similar, and it's not statistically significant. In terms of maternal mortality, again, we see that the effect is very small and not statistically significant. When we turn to height for age, it's still small and not statistically significant. The baseline incidence of infant mortality and maternal mortality is very low, given that this is sort of rare events. When I correct using rare event logit for these for these events, the results still not statistically significant. So it appears that this program is very successful in improving access to doctors and midwives, but the changes in utilization isn't translating into better birth outcomes, which is something that we ultimately care about. So given that there's this increase in utilization, there's a demand shock, is there a supply response. So this is changes in the number of providers at the village level. So villages are asked how many doctors, midwives, and traditional attendants they have access to. So here, there's no significant effect in the number of doctors, but there's a 0.1 increase in the number of midwives, and there's no significant change in the number of traditional attendants. So there's no change in the number of doctors or traditional attendants, but there's a 10% increase in the number of midwives. Given that there's this supply response, we expect this to mitigate some of that price increase that comes from the demand shock from the CCT program. So now we turn to whether or not households are paying higher fees for delivery assistance as a result of this program, and whether or not they have the resources to be able to afford these services. So in terms of the unconditional delivery fees paid, there's an 80,000 increase in delivery fees paid overall, and that's more than a 50% increase off of baseline value. They also report spending 70,000 more on doctors and almost 100,000 more on midwives, and that's actually a 150% increase off of baseline value, which is substantial. But given that there's this 40% increase in utilization, this is actually not too surprising. Because they now use less of traditional attendants, there's actually about a 30,000 rupiah decrease in spending on traditional attendants. So when we think of households that receive the minimum transfer of 600,000, the average spending on delivery assistance is about 30% of that transfer. So in terms of the affordability of care for these households, the program is actually good at providing these additional resources. This is the changes at the local market level. So this is based on the midwife report. Again, there's about one midwife per village. So midwives see both participants and non-participants. So what they charge captures the local market conditions. The first column here is changes in midwives' total income, which could come from either increases in quantity or prices, and it can come from any service that she provides. There's about a 300,000 increase in income for midwives. That's about a 10% increase off of baseline value. And when we turn to just delivery fees for normal delivery, for public fees, as expected, we see no significant change here. But when we turn to private fees, there's a 30,000 increase in private fees, which is about a 10% increase in price. So here we see a 10% increase in an average price associated with the program at the market level. So this affects participants and non-participants. This is a potential concern when we think about the affordability of care for poor households that just missed the cutoff for the CCT program.
Maggie, so I asked on that, do we know for the PKH beneficiaries whether or not their increased use of midwives was increased through the public services or increased via the private? Was that not known?
We don't know that, unfortunately. So I can't do a diff and diff on that because it's only asked in the follow-up survey. So looking at the follow-up survey, the probability of private service is not statistically significant. It's positive but not significant. So I can't say conclusively that it's because they're shifting to private. So next I turn to changes in prenatal quality. The first two columns is based on the household report. The first column is the placement effects, so that's the reduced form among households that happen to live in treated areas. They report a 0.08 standard deviation increase in prenatal quality received And among program participants, there's a 0.17 standard deviation increase in quality received. So it looks like, consistent with increased utilization, they are now receiving better care as well. However, when we turn to the midwife report, in the third column here is the public practice, and the fourth column is the private practice. The estimates are not statistically significant, so it looks like midwives are not doing anything differently, given that there's this possibility of quality decrease as they see more providers. This is something that we can be cautiously optimistic about, because at least the quality did not go down, but it didn't increase either. So when we compare the household report to the midwife report, the quality improvements that's reported by households is really driven by changes in utilization and not because of changes in the market. When I look at changes in quality conditional on going to midwives for prenatal care, the estimates are not statistically significant. So really it's driven by changes in utilization and not by the fact that these households are now seeking better care. The seeking better care part comes from the increase in prenatal care from midwives. But the midwives themselves are not doing anything differently, which is a potential concern if we're thinking about sort of strengthening the health workforce. But of course, this is a demand side intervention, so there's no supply side intervention here. Before I go into heterogeneous treatment effects and robustness checks, are there any questions?
About 15, but I'll do them all at the end. I'm saving them up. Okay. Well, what's easier for you?
So we'll like just focus until because
we'll
there is
finish
a
it
lot
up.
of questions.
Yeah, exactly.
Okay. All right. So in terms of heterogeneous treatment effects, one potential concern is that poorer households are experiencing the higher fees, and I don't find any evidence of that. So it looks like the price increase is not concentrated only on program participants who come from the first and second quintile of per capita expenditure. And actually, the poorer households are the ones that report receiving higher quality, which is consistent with the fact that these are the households that are most likely to be program participants. They now go to prenatal care more, and so they actually report receiving better quality. The next thing is to compare Java and off Java, which is what the impact evaluation has done. And there's actually a higher utilization increase in Java, and it looks like the program is more effective in Java, and it's quite consistent with that. I find that households report a larger price increase off Java, and they report a quality increase in Java but not off Java. So this is very much in line with the impact evaluation, that the program seems to be more effective in areas that are more supply ready, which is Java. The same thing when we look at midwives, there's a larger price increase off Java and no quality change in either Java or outside Java. So the larger price increase off Java is a potential concern when we think about these off Java areas are more rural, there's less supply readiness, and so when you're starting a demand side intervention, the larger price increase is a larger concern for those areas, not so much for Java. When I look at changes in outcomes based on baseline quality as measured by the available prenatal quality at baseline, there's actually better outcomes in areas with higher baseline quality, which is consistent with the need for supply readiness at baseline. So there's still no effect on infant mortality here, but when I look at the interaction term between being in a treated area and having an above median baseline quality, there's a 100-gram increase in birth weight here, and there's also there seems to be a decline in the incidence of low birth weight in areas that have higher baseline quality. So this suggests really the need to this suggests the need to have the supply readiness before implementation to sort of guarantee the effectiveness of the program. Next, one concern is the possibility of sort of price discrimination, where midwives know where the price increase may be higher among non-participants who just missed the cutoff. And I find no significant differential price effect among households that just missed the program cutoff as defined by per capita household expenditure. So most of the program participants come from the first and second quintile, so I look at the differential between the bottom two and the third quintile, and there's no significant effect there. And the other one is price discrimination among program participants, because there's this differential. There's a range of transfers depending on household composition. In terms of price discrimination, it's possible for midwives to know that households that receive the maximum transfer to charge those households a little bit higher. I actually find no evidence of this differential increase, which I think is something that we can be happy about, that midwives are not trying to price discriminate and try to extract a little bit more out of program participants. For a robustness check, one concern is midwife selection. There's this 10% increase in the number of midwives, but are we getting sort of the worst midwives around to enter into treated areas? So I find that the new midwives are more educated, but they're also less experienced. To the extent that both education and experience contribute to quality, it's not clear where this is going. The other concern is the possibility of midwives moving from control areas to treated areas because they know that there's a demand shock there. So I look at whether or not the control areas are losing midwives, and I find no evidence of that. So it doesn't seem that midwives are migrating into treated areas because of this program. The last thing that I check is the possibility of perverse incentives on fertility. In particular, we worry that because the cash transfer comes with being pregnant or lactating, the program might reduce birth spacing so that women can then receive additional transfers from being pregnant. I find no perverse incentive here in the timing of birth, but I should note that we cannot say anything about completed fertility because this is only 2 years after the program. It would be interesting to look at sort of completed fertility to see whether or not there's any effect there. To summarize, I find that PKH is very successful in lowering the barrier to healthcare access, especially in improving the utilization of midwives. There's a 40% increase in the utilization of midwives for delivery assistance. There's a price increase in response to the demand shock. In particular, participants pay higher delivery fees, but they also report receiving better quality of prenatal care. At the market level, midwives charge 10% higher fees with no quality change, and this is a potential concern if we worry about the affordability of care for households that just missed the cutoff for the program. So to conclude, I find that the supply response and a demand-side intervention is important as evidenced by the price increase, and the evidence is consistent with the need to strengthen the quality of care so that we could translate increased utilization of healthcare to better health outcomes. And as this program expands, particularly to areas outside of Java, it's important to consider not only the number of providers that's available in an area, but also to consider the quality of care and to consider the potential price increase in areas that are less supply ready. So thank you very much, and I'll take questions.
I'm sure there will be a lot of questions. So let's probably start with the first section for 4 or 5 questions, and then maybe we can have a chance to answer. I know that you would like, then who else? If not, I would like to add. Ada lagi? David.
Okay, I'll just do the top 2 and let others show. One that I think is particularly important is whether you looked at other health insurance status at all. Jump Asal, Jump Kesmas, Jump Kestar, you would expect to make quite a significant difference, and particularly in the population you're talking about. So that was one question, and linked to that, so this is still one question, whether you looked at any area-specific PERDA. For example, there are a number of PERDA even at a sub-district or even village level that could affect this substantially. So we know, and dare we all speak to this as well, we know that in certain areas in NTT, they actually fine women for birthing outside a facility. So, and that was introduced, I know that at least for 2 areas that was introduced during the period of your evaluation. Okay. So it would need to be something to be considered as well. My second question is whether you didn't just look at, I was interested in the 10% price response per attendance, per birth for the midwife, which is more interesting than the overall because that gets mixed up with utilisation, etc.
Right.
Did you look at total out-of-pocket expenditure amounts? Because what's been found in a very interesting study recently in India, not unexpectedly, is if PKH is also not just trying to get, and it's big if, just get the increase in utilisation, but also protect against poverty that causes. And what this India evaluation found out is that actually out-of-pocket expenditure overall went up, not only because of the fee, but because then the access, and we know that in Indonesia one of the biggest barriers is transport and transport cost. And so if you're actually incentivising now to go, and that there's transport cost associated with that, potential lost income, etc., then did you look at potential perverse incentive of actually increasing poverty rather than decreasing it? So they're my top 2 questions. I've got 4 others, but I'll leave those later.
Thanks for a really interesting presentation. I look forward to maybe following up more and discussing more. Debbie mentioned some of the points I also was curious about, and I would just expand. You mentioned in the paper that this was piloted initially along with Campaign Generosity.
Right.
So in terms of the block grant program that is supporting increased access and utilization, I'm just curious how you, because it also gets to Debbie's point about out-of-pocket expenditures on access barriers related to, let's say, geography or otherwise. How do you control for the block grants that are potentially being used by community on a community-by-community basis to try to, which has been illustrated to show increased utilization, right? So how do you control for the funds that are being used through that mechanism to increase access and utilization and potentially decrease, as Debbie is pointing out, or tackle the out-of-pocket expenditure challenge?
So there's no overlap between PNPM and PKH, at least not at
in the areas.
In those areas. So
Okay.
so at least I don't have to worry about that.
That's good.
But I guess as the program expands, that's certainly the attraction of those 2
Absolutely.
is certainly something that we have to look into. For other insurance, I actually find no evidence of increased take-up on any insurance in this data set. Of course, it's only been 2 years, right? And Jump Persal was not asked because Jump Persal just started in I think 2011. No?
So this data is at the end of
Because this is for 2009.
The end of 2009.
So it's right before the beginning of Jump
Yeah,
Persal.
so that one is very interesting, in fact, because it's supposed to
It
cover.
would be, right.
Which
So-
answers our question about the fees that you mentioned.
Yeah.
Because Jump Persal effectively
Right, Jump
gets
Persal would
rid of-
affect that right away.
In theory.
In theory, exactly. And I did not look at the specific memo, but I really should to see what other interactions could come through. Thank you. look into it. For the total out-of-pocket expenditure, this is looking at just the delivery fees, but I did look into total prenatal, delivery, and then postnatal. But I know you're thinking more on the transport cost.
And loss of income.
Right, and I didn't look into it, but that's, yeah, that's something.
I just found that paper that it was published just at the end of last year by the World Bank in India. Very interesting.
Yeah. Yeah.
Okay, so myself, Matthew, who else would like to ask questions? Maggie, again, thank you for a very interesting paper and presentation. First, I would like to check with you, as you know, or you might know, that not all kecamatan at the end, like the control becomes, some of the controls becomes aggressive kecamatan.
Right.
Did you control for that, like using the intent to treat, etc.?
Right, so I did look at that as well.
But you also use the intent to treat as
Yes.
the instruments.
Correct.
The other one, it will be good. Maybe it's in the paper. I haven't really read it carefully on like trying to really get a sense the stories of like midwife versus the dukun kind of like battle. Like what's the story styles in terms of do we see a different pattern of like utilizations between prenatal, the delivery and postnatal, vis-a-vis using dukun versus using the midwife. It will be good if we can get further stories on that. The last one is like on our impact evaluation, we saw a lot of spillover effect. Did you try to also look the spillover effect on this variable that we didn't see, we didn't check in our previous impact evaluation?
I did look at spillover on prices. I just tried to look at whether or not there was differential price increases, and that doesn't seem to be.
What about the use of midwives?
Spillover on the particular ones? I did check it, and I unfortunately don't remember. But I think there is something there. But I'll get back to you on that one. But midwives versus traditional birth attendants, for prenatal care, there's really no prenatal care for the traditional birth attendants. They're just there for the delivery. I think that's why the complications then don't get detected and there's no referral, et cetera, et cetera. But beyond that, in terms of sort of the quality of the midwives versus the quality of the traditional attendants, I wouldn't be able to get at that because there's no traditional attendant questionnaires. But it might be possible to look at sort of just the delivery itself, and look at more characteristics in the delivery to see how different they are.
So when you look in terms of this participation effect, this is on delivery?
Yes.
Not
That's only on delivery.
Maybe so. And I think you rightly point out that one of the big policy concerns here is an increase in fees and what effect that's going to have on poor non-beneficiary household. So one thing, I'm not sure if you've done it, we could look at, the 17% increase in the use of midwives is a difference in difference, right?
Yes.
So this is treatment versus control before and after. So you could decompose that into how much of that is an increase over the baseline of beneficiaries or a potential decrease over the non-beneficiary baseline, especially you could look at interaction with poor households. So in other words, you actually have enough data to sort of say how much of this change is due to beneficiaries increasing use, but how much of this relative difference may also be
from the decrease in
we may actually be able to see decrease already in response to these fees.
Although, to be honest, from a policy point of view, that's less useful now that you've got jumpers on, which means that the fees are actually covered. So in fact, the more interesting policy thing is those other costs, not the fees.
Right.
Because they're not covered under jumper sale, and that's a big policy question at the moment, whether they should be.
But in terms of sort of the wider learning for this policy audience around the world, that doesn't necessarily have it, then she may be able to actually say what's going on here.
And also about 60% of deliveries, according to midwives, are done through their private practice. So I think Jumpasal does
covers
it.
private.
Oh,
Jumpasal does, Jumpasness does not mostly, but
Oh,
Jumpasal
Jumpasal.
does.
Okay. That's good to know.
It's a little bit, sorry, I know a little bit about the PKH, but not really in detail. My question here is like, based on your result, you said that there are higher prenatal quality. It means like actually there are some, like the pregnant woman really go and try to check the pregnancy during their pregnancy before they deliver the baby. But it's very funny that the outcome itself is not really significant, right? Even though actually, like you said that in the later on when you try to decompose it and then you find somehow that actually there are some increases in the outcome, but in overall there is no outcome. So what actually what the quality improvement during the prenatal that at the end doesn't really matter much in the outcome.
Right. So
I'm sure that you can.
right. This is looking at changes in sort of quote unquote objective quality measures. Did you get your height taken? Did you get your blood pressure taken? And there's nothing on nutrition, for instance, but through PKH itself. So it's not clear which component exactly contributes to the lack of outcome. But one potential explanation is that even though they are now receiving prenatal quality, that quality remains low from baseline. So that might be why we're not seeing this difference.
But you do get a positive outcome when you look at the high quality areas.
Exactly.
So you can look at what the different weights in the PCA are that call you a high quality area, and that arguably is contributing.
I could look at the exact components. Yes,
This is going to reflect in the policy implications, right?
Right.
Even if the PKH itself in general works. But then what
is like which components?
Yeah.
Right. Yeah, that's a good idea. I can do that.
Maybe you might, and Darren, you know a lot about these things. Because at the end of the day, what we care about is like how it can improve, for example, maternal mortality, birth weight. Is there any things that maybe should look more based on like your understandings? What are the main issues that make Indonesia maternal mortality 10 times higher than Malaysia, for example? Because people keep talking about too late make decisions to go to the midwife, too late of the midwife to make decisions to go for like the next level of like hospital. Is there anything that maybe should look more to try to get a sense?
I did try to look at whether or not there's any visit in the first trimester, and that looks there is an increase there. So it looks like you're catching them early enough through this program.
Except most of the complications that relate to maternal death are unpredictable. So there is some association, but very low association in Indonesia between high risk, like previous complications, and actual subsequent complications and maternal death. It's there still, as you would expect, but much lower than some of the other factors that lead to maternal death.
Okay.
But just on that, and one of the things, that we were discussing over here is whether, and it relates to Phoebe's point about the going late, whether you looked at births in facilities versus skilled attendants separately at all, because that access to care, and particularly even, I know it's very difficult because you're dealing with small numbers, so even what level of facility, because again going to a puskesmas in terms of access to care, complications and speed of that is very different from birthing in a polindes in the village with the village midwife in the household versus having the village midwife go to home. So that was one of the questions that does make a big difference. I think looking at the nutrition and birth outcomes together will be hugely important, because a massive proportion of both the maternal and particularly the newborn death in Indonesia is related to nutrition. So given that PKH is actually dealing with both of those issues, it would be a beautiful opportunity to look at some kind of combination of that. I think your birth spacing issue is really important for both maternal and neonatal mortality, and I think you raised the right issue there that it's such a short follow-up. It's very, very
too difficult to look at. Right.
But just a comment on the non-significant differences as well. I know you use the logistic, and now the econometrics comes in. You use the logistic for the rare events, but we know that doesn't fully correct for rare events.
Right.
And you're talking really low areas and over a really short time span.
Right.
So I would really underemphasize looking at those outcomes, because I think you're dealing with such small numbers that not even any model will adjust for those numbers. Yeah.
And the total numbers, of course, this is just only like in each of like the villages, one dusun and one dusun. It's very small. It will be very difficult unless like you accompany it with another data for that particular kecamatan.
It would be really nice to look at administrative data from vital statistics. That will give us a much better sense.
Exactly. There are some questions on the census. In the census, some questions regarding like death in the
past year,
in the past 5 years. Like I don't remember on top of my head, but there is.
I mean, in terms of like trying to understand more about the nutrition aspect and others, probably it's not, you don't really need to see the whole area Indonesia, because you can have a lack of data in general. But if you can like focus study in the certain area that have some information, like some districts they have dinas kesehatan, some they have
also
very good data from like the puskesmas. Puskesmas they have to report to the district, but they're not in all districts, because it all depends on the decentralization issues, and others is also like that like some area trying to
nutrition is actually in Susanas as well, and that's valid at the district level.
But check with the census, because this is 2009, end of 2009, and there will be a 2010. If I'm not mistaken, there is some questions regarding when was the death.
There are.
The other thing I think you can be doing too, what's really interesting here is what's the broken link between increased participation and the outcome, right? And it could be quality, but one of the things you could look at is yes, there's an increase in participation, but over how many times? So I think it's meant to be 4 prenatal visits and 2 postnatals, and so maybe going from 1 to 1.5 isn't enough to drive outcomes. And so is there some sort of a threshold? Can you divide the participants into some sort of a rate where there's a tipping point at which participation, but sufficient participation kicks you into getting some sort of outcome, not just the quality thing you're finding in high areas?
That it's not, the maternal deaths are not necessarily as affected by prenatal visits, but you have, I'm actually curious about this impact evaluation survey that you cite on slide 10. Because I didn't know if that data fed into the prenatal quality information that is listed elsewhere. Because it seems like you had said earlier in the presentation that prenatal quality is driven by participation, so that just utilization, right?
Right.
But do you have information on whether women took iron pills or some of those?
So that's an interesting one. They receive more, but on the compliance of actually taking it, it's not.
And the interesting thing,
they get it, but they don't take it. That's sort of one of the
And the interesting thing with that is at least some qualitative work would show that that's partially because of them, but actually partially because of the midwives. So the midwives give it because they know that these programs, etc., require it. But they say things like, "But it's going to make you feel nauseous." So don't take them if you don't want to. Just go. We know that from quality.
Isn't it folic acid is very important?
To be honest, it doesn't make you feel nauseous that much. It's taking it with some food. They taste awful at the moment, so that there's some work looking at whether sugar coating them will actually help compliance. But we have to work a little bit, I think, on the
Iron and folic acid is different. Yes.
So folic acid, I think you're supposed to take it before.
Before, because I remember when I was pregnant, like, oh, folic acid.
Yeah, that's for neural defects in a child, as well as actually increasing. I mean, you should take the vitamin C with the iron to increase the uptake of the iron.
Is there any more like uptake of like? Did you also look at folic acid by itself?
No, I actually didn't look at folic acid because it's not required by the program, but I'll look into it. Yeah.
In fact, in general, on this quality index, I mean, PCA is a little capricious.
I did look at the component by component and tried to test it jointly. It's a lot noisier, of course, and not as significant.
Maybe another. But one more. Are there any other questions? Smita, would you like? Yeah, Cindy.
Making some interesting.
Oh, yeah.
What I know in the CCP program, there is also not only the money distribution, which is the respect of what is important is the assistant or the facilitator to push the mother to go to the posyandu and to go to school, etc. Do you have information about that? Because this is an important role. Yeah. Because the mother not only they got the money for anything, but they have to use this to buy the nutrition food, and they have also to go to school and their children and so on. Without them, I think it's important anything else.
I actually don't have data on the quality facilitators, but it would be interesting to try to match the survey data with the facilitators and see how that match quality affects participants.
Actually, this is a question for the room. Has there been any better evidence on child spacing impact done to pick it up? Like this is only after 2 years, correct? So has there been anything else done?
On PKH? No, currently TMP2K is preparing another round of surveys, but it's still ongoing, even like not yet.
There's no data. No data yet.
No data yet, because PKH is too small.
It's raised a lot, that argument.
PKH is too small, you cannot really get it on the previous Susanas to ask questions, but like starting this year Susanas, they have additional questions on PKH, so we can know better. And also there will be additional, like another round of impact evaluation surveys.
Actually, that's also my question. I think that's the big question when we talk about PKH, because I have no idea about PKH before, but when I read this page 7 in your paper, the first paragraph there, I just realized that PKH is consists of two projects. I mean, in health and education, isn't it?
Mm-hmm. Yes.
And the location.
It's one project, but with conditionally two components.
One project and two conditionally service that need this and it is said here in the pilot sub-district. This district is considered as the ready supply location, meaning that I mean this needs to be clarified. What do we mean by ready here? It is include the quality of the provision, public service provision in that education and health sector, or else. And what is the definition of ready supply here? Secondly, we could also, if we want to have a clear picture about this PKH, I think we need also this kind of study in the other side, that is in education, because I have like a perception maybe when a household got 600 up to 2,200 rupiahs, maybe they tend to use more for education, for transport and so on, for their kids rather than for health. It could be like that. I mean, how big is the impact of this PKH program in the education sector? It could also some explanation to your study. Thank you. I mean, if there is study, not from your study.
Right.
Yeah.
So, well, the impact evaluation, education is not much, right?
The impact evaluation, but it could have been a question of the indicators that we used, because the enrollment rates were already stayed pretty high.
90-something.
It wasn't necessarily looking at attendance or transitions or something, but yeah, no evidence yet.
And also for education in terms of the dropout, what happened is a lot of the dropout happens at the end, like on the transition years, from grade 6 to grade 7, from grade 7, from grade 9 to grade 10. And PKH was not there during those transition years because like, it's usually the first payment is like way after academic year started during those. Only recently some part of PKH beneficiaries, new beneficiaries got the monies like before the starting of the academic year. Maybe Ari would like to add more about like on this new, including like what NP2K plan to do an evaluations of the PKH.
Well, first of all, there is an expansion plan to expand PKH in other areas. In particular, the eastern part of Indonesia, which I think the supply side will be more of a challenge there. But I think a challenge, but also in the sense that in terms of the study, that given that you mentioned earlier that the previous ones is, the sites were carefully chosen, that the supply side is pretty much ready. So because we want to test all the conditionalities and we don't want to see that the PKH performance is limited by the supply side. But of course, now the question is that if we want to expand in more remote areas, whether there is a demand shock which will trigger a supply shock or supply response in those areas. But yeah, it will be expanded into some areas, including the eastern parts, and yeah, we are planning to do the evaluation for that. But it's mainly on the plan, still on the plan, because there is the plan on doing the follow-up survey. But on the new sites, we are planning to, maybe later jurists can also help me in explaining this about the plan. But there is an idea to do further impact evaluation of these new areas for the expansion sites. But this is as much as I can say today. Because one, the plan still under review and considerations. Although of course many of us are really interested in doing the study for the locations.
Just one quick on that. I mean, obviously that timing then is going to be timed with the rollout of Jamkes Nationals.
Yeah.
So you'll need to look at that carefully in that evaluation, because the effect of that on utilisation will dwarf probably anything that's going to happen.
And also Jampersal, yes.
Jampersal will be there already, and it is there already. It's going to continue, although some of us don't understand why. But you'll have, and you're having 10 million people minimum per year added over the next few years to Jamkesmas, with, we hope, a more efficient management system, etc. of it. So the utilisation increases that you're going to get in that would be significantly more.
The constraints are like transportation costs and opportunity costs and so forth. PKH could be, it could actually be quite interesting, right? Because if you start to get much better coverage of Jamkesmas, then in theory there are no fees for people, and if the real constraint is if you didn't see a differential impact, it could be.
They're also expanding generosity.
But generosity, you'd have to look at the overlap with generosity.
But it's also interesting because as they're expanding generosity, and I think this is an interesting sort of, when you, back to your point of in terms of policy issues and recommendations, then the question is in terms of facilitators who are trying to maximize allocations at community level with a view toward increasing improvements in those indicators of interest, which are the generosity indicators and the aid on health. in terms of decreasing access barriers, you'd like to see, therefore, a sort of, even though it's an open menu grant system, you'd like to see sort of perhaps some level of, I don't know, proactivity around trying to decrease any remaining access barriers, particularly physical access barriers that you can't tackle perhaps around, through some of these other interventions.
just fewer demands on
basically you need to look at the whole thing three-dimensionally as one complete, many government programs in one, and how do they complement each other?
We actually have like a long discussions with Rob Robel on this PN generasi PKH. Instead of like looking at it like as a battle between two programs, it should be more like what are the comparative advantage of each of these programs. Because in a way, PN generasi shouldn't provide money to just like as acting as a conditional cash transfer by itself, but you should try to make sure that PN generasi is like addressing the accountability mechanism, addressing the supply side issues, and pushing for better supply side issues, pushing for better quality.
They can't tackle supply. I mean, the challenge on that.
Small supply side, not the whole.
I would be happy with that, but I mean, I think my SD colleagues would feel
we have a lot of discussion on like some small supply side issues, or even like pushing the accountability. What are the things that's still not being done, that money only through PKH will not generate anything?
It'd be a very interesting conversation across, all of us working in health and SD and print, about this kind of like how can we together support government trying to, see these things in a very
So we probably need to
integrated
revive those discussions again of like having this one. Instead of the silos, even at PN itself, not only just PN generasi, PN, PKH, etc. We discussed a lot, but I think it's been a year ago with Rob how to make it translate into action something.
So at the moment, I think anecdotally, right, there are some sub-districts where it wasn't intended to overlap, but they did overlap. PKH generasi. It's very, very small number, but we went to these overlap areas. And what we found is consistent with what we are already doing, which is that generasi actually in those areas are used very flexibly to just close whatever gaps that PKH didn't close, right? So in fact, it didn't just build roads leading to the health clinics, it also covers some of the demand side gaps. So people who suddenly got into a disaster, like their breadwinner died in an accident, and they can't get PKH because PKH has very inflexible targeting systems. They get generasi.
But currently, especially with the NP2K, all these targeting, exclusions, errors, and etc. with the expansions of PKH, it should be something that pushed toward the PKH or even the NP2K should the allocations of the monies and needs to address some of this exclusion error. But on specific use that, it will be better if it is like focusing more on the small supply side issues.
Or as you say, the community accountability. We were all furiously nodding over here because we're about to go and have this conversation in a coffee shop afterwards. But I mean, well, Vivi, as you know, and Rob's been involved as well, what we've been trying to do, and there's been a bit of delay, and Scott's back, I think, to reinvigorate us. In AusAid, we've been talking for over a year now about actually purposely designing our programs, or the programs that we support that are government programs as well, together in the same areas with a uniform results framework, etc. We're calling it frontline improving frontline service performance. And so we're specifically and about to go exactly to have a discussion on PNPN now. So our health systems and our maternal and child health and nutrition program, which is working largely on the supply side, where there's demand side things, we'd much rather work through the existing programs, but actually make sure that we're jointly planning, that there's a joint governance type structure, monitoring structure, etc.
So we also have this, we had a discussion with Bappenas like 2 weeks ago when we were discussing about the expansion of the MPN generasi coverage area, because we're looking at 500 sub-district by 2014, and there's possibility of 800 until up to the 2017 because of the MCC coming in. And one of the discussion is also to look at how does the distribution of the location of the generasi could actually complement the work for PKH. So we are also asking where is PKH location, and then we can share and then we can provide this together to address the social supply problem.
Actually, I'm afraid that from the at least this is just anecdotal evidence, right? Based on the visits that we do to the generasi PKH overlap areas. I'm afraid that the fact that generasi is closing the gaps that PKH doesn't address, it doesn't say that generasi isn't complementing PKH from the small supply side. It just points out to PKH's sort of like the gaps that it doesn't address. Right?
The exclusion error. The exclusion error.
It's not just exclusion error, but it's also the amount of money that is given through PKH, like whether it's actually enough or not. Like generasi is closing more of this. And it just shows that the community thinks there's more need than what PKH currently addresses. And it's such a small, tiny program. I don't even,
Question maybe for Debbie. How much narrower is the window of the menu for the MCC generosity area? Is it the same broad menu that they're assigned to, or is it?
No, they're buying into the same. It's one generosity. It's government program. So the MCC funding, well, not MCC, but the MCC funding or any other funding, multi-donor, etc., is supposed to basically abide by the existing government rules and regulations around.
Because it is labeled a stunting project, so I just wondered if they were targeting a little bit more.
Well, on the supply side, I mean, there was also interest in maybe adding an indicator, they still may, on the generosity program that has a sort of a proxy for stunting. But it's more on the supply side where the MCC funding is what's supposed to really focus and address some of those constraints related to stunting.
Getting the household and the community level data to merge between PKH and generosity is kind of the difficult part, because one is targeted at the household level and the other is not. So, I don't know, as a stunting project, you see where PFP and generosity is the opportunity to maybe merge here.
And then your stats can come at the sub-district, district, whatever level with the stunting at least. So I think a lot of us that be working at least in some way conjunction. I mean, the MCC money is actually putting money through PNP and generosity, us working in the same areas, but both with a stunting focus. Yeah. It'd be nice to see PNP and develop that indicator.
Okay. Are there any more questions? Sydney?
I had a question, and the general audience may already know the answers to it, but I just wanted to ask you, because I found the public-private breakdown of midwives' work interesting. Specifically the fact that utilization is not decomposed between public and private, right? So you just ask women if they want to see a midwife. But did you find, I don't know if you did this analysis, but did you find that there was some, did midwives game the system a little bit by saying, I'm going to give less of my time to public?
I did look into it. The hours worked in public and private didn't change. Okay. But given there are more midwives now, it's really hard to say. Right. But, well, there are more midwives, so I can't really change.
That incentive's so strong already that I'm wondering whether the small amount of
I don't know enough about how the hour breakdown happens and whether it's monitored. Because I find it really unusual in other countries, many other countries, you're not supposed to have a private practice.
Right. Is that data and self-reported?
This is self-reported,
exactly. So, it would be nice to be able to match sort of the business month data and sort of the self-reported. Because anecdotally, we see that they will cut hours, right? But it's not, maybe, I don't know if it's self-reporting, then they would. If it's self-reporting, I would say, because we would ask them, what is your official hours? And they would tell us the official hours. Right. But actually, if you see the signs in front of their offices, it's not the official hours. It's like the
But if you're asking women themselves whether they were charged at private or public rates, then you could see that.
On these quality issues, I think it's something that's very interesting to look for, especially with the STSN later on, universal coverage. We know in Jakarta, for example, this like Kartu Jakarta Sehat already increased a lot of like utilizations and can affect qualities. Like really try to get a sense of what kind of qualities.
Right. What do we effects on?
There is one more question, and I think after that we should probably wrap up.
Yeah, I have a comment about the quality index here. You built the index using principal component analysis. In my opinion, this kind of index is data driven. You can you can get different result in different times or different observation, even using the same item. But for health issue, I think if we want to measure the quality, we should really base on the much more technical items, which kind of thing or items that really affected, for example, here to the prenatal care or something related to this. And I think you can try to build, for example, using opinion from expert or doctor. We can ask them to make a composition or of the dimension or variables that give effect to health of the respondent, for example, and the weight of each dimension or variables, it will be based on the knowledge of the expert, not just by the data. And I think it can give you more clear or the exact meaning of quality that you want.
But you also did not only
did
just through this
item
one,
by item.
but item by item.
Right.
I think so it will be
So
good.
it might be in between. Yeah, what you're suggesting should give me something in between.
And the bank more and more is trying to tackle this. How do you measure quality? There's been a lot of sort of experiments with it, and using vignettes, etc. And actually, I think President Kimmy brought us out recently to do a presentation at the bank on this. But I know there are a lot of. I mean, it's a big issue, of course, and I think you're absolutely right. And it's how you measure it could diverge significantly depending upon exactly what you're measuring, and it's really hard to capture. And that's why they're trying to use like vignettes, but even that is sort of a time-based issue. It's challenging. So, I mean, there's probably no perfect science, but it'd be interesting to see if there are ways to improve the measurement.
Well, and who you're asking, because where this is a survey of the recipients, their perception of quality is very different from actual technical quality. So I completely agree with you, but to do that sort of thing, you actually need to be collecting specific data from facilities, and it's so labour intensive, etc., to do that. So yeah, just to support what Darren said, I think there's a lot of people trying to look at the best ways of doing that at the moment, and every country in the world ends up doing some sort of structural measure of quality. Is this equipment there? Is that there? Because it's so much easier to measure.
Right.
But the tetanus vaccinations and the iron pills, I think, in particular, because infections is it shows such variation in Indonesia, the tetanus vaccination, and also, but again, this isn't for maternal deaths so much, but for neonatal deaths, it's really, really important. So.
Thank you very much for coming, and Maggie, thank you again for a very interesting presentation. I would like also to remind the audience we will have another Forum Kajian Pembangunan hosted by the bank this coming Wednesday on the 27th, and it's on impact of services reform on Indonesian manufacturing sector, and our senior economist Samsura Harja will present. It will be great if you guys could come.
Thank you for arranging this. This was really great.